Hey guys, um, make sure we're good with the audio and visuals. So,
I
yeah,
think some people left some messages over in the chat.
let's go from Get Shifty, Gout Foot here. For the people who are already in the chat, okay, things are up and working. For the people who are already in the chat, could you guys just leave your initials just so we can kind of know who joined and we can send you guys some helpful information after as well. Just waiting until 7:30 and then we'll get started. We'll do a slow rolling start, just see if a few more people join us. All right, so we'll still give a couple of minutes for people to join, but I'll just get started with briefly just chatting about what I wanted to talk about today, as well as give you guys a chance if you have any questions to ask them in the chat, and I can go ahead and answer them as well. So today we're planning to just go through the anatomy of the ankle, some common patterns of injuries, and how to kind of look at your own ankle injury and see, hey, like, is it following one sort of pattern or another? And then from there, that really, excuse me, gives you an idea of how you can go about managing it and give you some insight on how we at Rehab Hero or physiotherapists, chiropractors in general go about our assessment for these sorts of injuries, and then from there we go about making our plan. So really everything is rooted in identifying what we think is going on and working together with whoever we're working with patient wise to identify their goals and work towards getting to there. Still just waiting a couple minutes. I know that based on the survey that was filled out, some of the common or themes that I saw was Achilles a couple times, foot mobility. One person indicated they had an ankle surgery. And another person was talking about they want to strengthen their ankles. And we have one patient who's, I think, here, according to Gout Foot here. Okay. Is the audio okay? Can you guys let me know? Mm-hmm. Comments. All right, I'm going to go ahead and just get started continuing with what I was talking about. So, audio's good. Audio good, mate. Thank you. Okay. So, let's start with the anatomy. Sorry if I'm a bit nervous. First time for myself doing this sort of thing as well. So when we're thinking of the ankle joint, mainly looking at these two bones of the shin here, so your tibia, fibula, and they form the true ankle joint here with this bone here called the talus in the front there. So what I want you to appreciate is the mobility that's available there. So this allows your ankle to be really flexible and be a point where you can really pivot and do a lot of movements. So what's important to note is the ankle itself and its degrees of freedom or how much it can move means that it needs a lot of soft tissue structures, so things that aren't bone, so ligaments, muscles to help facilitate all these actions and also help it connect with other areas of the leg, so namely your foot and your knee. So you have muscles that run along different areas of the leg and attach to the ankle joint. So you have commonly on the inside, which is most important, is tibialis anterior, which is important for this upward motion of the foot. You have your plantar flexors, which are running down the back, which are involved in this motion of the foot, and they attach to the Achilles tendon, which you might hear often is involved in tendinopathies, tendonitis, or even torn with some cases, like Kevin Durant, if you guys remember seeing that nasty injury. And then you have the peroneals, which come along the side. The reason I'm going through this, the main thing is just appreciating that. I think I dislocated his knee, but just appreciating that you have muscles that start near and at the knee or right below the knee on the shin bones here and come all the way down and move the foot. So that's how you kind of have that connection. Sorry, I'm blocking this. You have that connection between the knee and the foot. And similarly, you have smaller muscles that connect you have smaller muscles that connect from lower down and onto here and attached to the foot and allow you to really have a nice ankle foot joint complex and ankle knee complex. So put this guy away. Oh, lastly, one thing I wanted to point out was you have your ligaments that are sprained or in some severe cases torn when you have your ankle sprains. So those come along on the side here and attach at different points of the ankle. Some are also from just the foot bones themselves. And those are on the outside and on the inside. And depending on the way your foot moves, if you go in this direction, you'll sprain the outside ligament. So that'll be your inversion sprain, which is much more common. And you have your eversion sprains, which are less common and require more force and typically don't happen as often. So regardless of the fact, so we got through some of the anatomy. I'm just going to open up here. Does anyone have any questions about the anatomy of the ankle at all? Got Brian, hello, audio is good. So see if anything comes up. Okay, so I'm gonna get into a bit of how you want to go about like thinking about injuries. So I'll go into a bit of what to look for and then some examples as well. So first things, let's say you come into clinic or even if you're at home looking at your own foot, you want to assess the basics. So you want to look at range of motion of the foot. So you want to see, are you able to go, I'll bring this guy back up. You have just your standard range of motion with going downwards with plantar flexion or with 50 degrees, upwards dorsiflexion of 20 degrees. Usually with ankles, this motion typically tends to be okay, but coming upwards or the dorsiflexion tends to be limited. I know one of the people in the chat here, we've been working on trying to get some more of this motion, the dorsiflexion of the foot, and that's really important for helping with walking, because if you don't have enough of this motion, you won't be able to clear the floor, so you have to drag your foot or you'll compensate in other ways. And why that can be limited is either tightness of the calf muscles in the back or weakness in the front here where you're not getting enough strength to lift up in the foot there. And that could be not just involved in walking, or it can also be involved with running. And it's typically limited in a lot of cases with the ankle, even if it's not with the structures I mentioned already. And then, so let's go with that example. We'll talk about Achilles tendinopathy or tendonitis. So that's an irritation of the tendon of the Achilles that attaches here. So you have your calf muscles that come in and attach at the back here onto the heel bone. So typically these injuries are due to overusing the muscle. So overusing the muscle. So let's say your tolerance to load would be here, and the activities that you're doing, let's say running, playing basketball, whatever it so be, or all those things combined are here. So you have this discrepancy between how much load that your Achilles is able to handle, so how much strength you have, and how much demand you're placing on it. So at first, usually this becomes okay, but what tends to happen is you start to have eventually your body begins either compensating and you kind of begin to impact other structures, or if it's truly just a singular Achilles injury, then this kind of tolerance load begins to come down and you start to have some changes in your tissue. So you start to have some damages, and that might start to be like if you go for a run or if you play basketball, the next day it'll feel sore, but it won't feel sore right away. And then it'll feel stiff at times, but it might feel stiff at times, but you really feel that movement helps to facilitate it, and it's very load dependent. So the more load you put on it, the more irritable it'll be. And if you continue with doing what you're doing and you don't take the time to manage it, then it can go into the other phases. So in the beginning, it's more of just an irritative, reactive stage where the recovery time from there is pretty good. But then if you allow things to continue, it goes into more degenerative changes where in the next few months, it's still reversible but if you continue and really start pushing the tendon, it goes to a more irreparable phase. So you might start causing some long-lasting damage of the tendon. But even if, let's say hopefully you stop it in those first two stages and don't get to the third stage. However, if you get to that last part, then you're able to still use other areas of the tendon that have not been damaged yet. So it's not like your Achilles is done for good. So the management for that, what that looks like is first you gotta, whether you're coming to see us or whether you're seeing someone else or whether you're just managing this on your own, you want to first identify, okay, what is the amount that I can do where I'm not aggravating the tendon. So you identify that, and then that's your new starting point. Even if you want to still keep using it, because with tendon injuries, if you completely rest them, that will actually not be beneficial in the long run. You'll reduce some of the tenderness that you have, but once you start getting back into what you got to do, then you're actually, that discrepancy, you've lowered it because you haven't been loading that tendon, and tendons are really responsive to load. Let's go into a bit of another example if no one has any questions about that. So let's go into dealing with something that's more with the hard tissue structures or the bones or things that are not as changeable. So I'll use an example of arthritis, whether it be osteoarthritis, rheumatoid arthritis, or gouty arthritis, as one of the people in the video, in the chat here mentioned they have, who's gout foot. You really can't change things to a certain extent structurally, so with the bones, but what you can affect is the muscles all around and increasing how much those muscles can do to offload and take on load from the affected joint, right? So whatever the cause of the arthritis is, you can limit the progress and also get back some of your get back some or even all of your function, really depending case to case where you're at, by going into first bringing down kind of some of the irritation, getting back to that range of motion that I was talking about, increasing the range of motion there. And then from that point, you would go into, okay, let's say things you need to do are walk 2 kilometers a day just with work, that sort of thing. Identify where your starting point is, and then with working together with the team here, we would then create a plan where we're gradually increasing how much you can do, and then also working on strengthening the muscles that are involved in that. So that might go into the calf muscles or the muscles in the front of the shin that we were talking about that do the up down motion. But now I want to chat a bit about the motions of inversion and eversion, which are done by the muscles that are on the side, your peroneals, and namely your tib post, which runs along the inside of the shin bone there. Feel free to stop me if you have any questions along the way, guys. But these muscles can be strengthened and really help with structural things like arthritis, because, for example, your tib post, which runs along here, and as well as your peroneals, but we'll talk about just the inner muscle there, attaches into the bottom of the foot. So it kind of comes along here and into your arch and attaches under here. And what it's really important for is helping maintain that arch. So if you or yourself or someone who has flat feet, you can usually suspect this muscle is not doing as much as it probably could, and can benefit from strengthening and help support the foot more, because the whole point of the arch of the foot is to support the foot and help distribute the load up the entire leg. So let's say the foot's more on the flat side and it's not a structural thing, it's more just due to a weakness, then if we identify that and work on strengthening that, then we can get the foot feeling really strong and also help offload, whether let's say you're not just having just ankle pain, but you're also having pain in the, or you're not having ankle pain at all and you're having pain at the knee. But if these forces are not being properly absorbed, then they can then go on to affect the knee, the hip, whichever area is involved. Any questions about any of that? I know I was kind of going through a couple things there. Come on, chat. Someone ask a question. Anything. Okay. Give you guys some more. Okay. Let's chat about, we got ankle surgery. Let's talk about the treatment after an ankle surgery. So this person wasn't specifically what the ankle surgery it was, or I'm not sure if they're in the chat, but regardless, same thing, comes back to those tenets of increasing range of motion, getting strength back. So after you have a surgery of the ankle, you can imagine that the foot's pretty stiff. It's had a trauma occur. So as soon as whatever is within the surgeon's tolerance, right? So some people have weight bearing limitations, so you can't get into the walking and such right away. A lot of people don't. So whatever it is, we work within that limitation, but most of the times you can at least start working on range of motion, doing exercises where you're just first not weight bearing, just getting the foot moving, starting to get some of the muscle activity back. And then you get into weight bearing stuff, so walking, um, eventually get into things like plantar flexion exercises, so calf raises, things with band exercises, and from there you take the person as far as they sort of need to go with that. And really the main thing with post ankle surgeries, you want to try to take advantage of the newly fixed structure that you have, namely that you want in that first little window, you want to make sure that you're gaining range of motion back, strength back. Because if you, let's say you were to I don't want to do anything, you wait 3 months after your surgery, and then you're like you come and you want to do a rehab process, you're less likely to do as well as you would have if you would have started right away or as soon as you were cleared to start. Again, feel free to ask questions. Otherwise, I'll keep going into these things. So let's go into a bit of more of clues of how you can kind of identify what kind of injury you sort of have. So you can kind of think of things in a bunch of ways. So first, you kind of try to identify the location, right? So is it actually on either side of the kind of ankle bones that you think of here? Is it truly in the ankle? Is it on the heel? Is it in the arch of the foot? Some people come in with ankle pain, but really it's not actually at the ankle, but just near the ankle. Is it in the front of the ankle? The location will already give you an indicator of what structures might already, be involved. So let's say we went on the inside last time. So let's say you're having pain on the outside of the ankle here, right? So a lot of times people present with pain on the outside of the ankle here. Let's say you were playing basketball, you landed funny, your foot came in inwards. So you can already get a lot of information from that. You get the mechanism of injury now. My ankle always cracks when I tiptoe. Is this normal? I'm gonna assume, I'm not sure where the ankle cracks, but typically with cracking, if it's not painful, you're usually okay in that sense. A lot of times, ankles cracking, if it's every time you do a movement, could just be tendons in a certain area. I'm not sure if it's in the front or in the back, but it could be tendons just moving and rubbing against each other or on some of the structures in that area. It could be indicating that there's something, there's some muscles that are tight, or there's some underlying reason why those tendons don't have a lot of room to move, but it really would have to be seen on a case-by-case basis. How does tightness in the calf and the muscles at the front present or affect the ankles? Tight. Okay. So really the simplest way to think of it is if the muscles at the back of the leg do this motion. So this is the muscle being in a shortened position. So if you had a rope, it would be in that loose kind of wavy form where it's not taut. Versus if you take it in the opposite direction of its movement, the muscle then, like a rope, when you make it taut, would get tight. So let's say you're lacking some of this motion, and then you go to try to achieve it and you feel a stretch in the back of the calf here. Then you kind of then know, okay, this is something that we can try stretching, and if it helps to make long-lasting changes to the range of motion, then we know that that's something that was affecting the mobility this way. So it's simply the fact that by going into this movement here, then you inherently elongate the muscles at the back. Similarly, if you go backwards go into plantar flexion, you'd be stretching the muscles in the front. So another way you could think of it is even like your bicep. If you shorten it this way, then the muscle gets kind of clumped up and gets gets shortened into a ball. And then if you go and stretch the bicep, then it gets longer and it's not as clumped up, so the muscle gets into a bit of a longer position there. And then I didn't answer the second half of the question. And muscles at the front present or affect the ankles. So yeah, like I was saying, so how it present really varies from person to person. You might even have tightness in the in the calves, but you have no issues at the moment. But it could be something that makes you more likely to have an injury in the future. One example that is pretty common that you might see with having tight calves and Achilles tendonitis or tendinopathy, where those calf muscles attach onto there. So if they're tight, they're exerting more pressure and there's more force being placed on the tendon itself, because every time you contract your muscles, your tendons are an anchoring point for this. Let's say this is the muscle, this is the tendon. So every time you contract that muscle, it's pulling. So that's how you can get some irritation of that tendon. If it's really tight and there's kind of not a lot of mobility and you begin to have some compensations, you might get things like heel spurs occurring or that sort of thing. Any other questions, guys? Otherwise, I will just keep talking about different conditions that I thought were relevant to you guys. So let's continue talking about the mechanism of injury. I know I was talking about an ankle sprain going in this way. So you sprain the ankle this way, you come into clinic or you look up where these ligaments are on the side of the ankle, and if you kind of match it up, and we'll do some special tests, which are orthopedic tests, where we're just taking the ankle through different movements to try to see if we can reproduce your symptoms. And then we find like we reproduce your pain, it matches up with the mechanism of injury. So we're kind of using a bunch of different clues. And if there's any visible swelling, if you have a grade 1 or ankle injury, it would be not too bad. You'd maybe it'll probably recover within a few days or about 2 weeks. Let's say you have a grade 2 or a more severe one, then you might notice some slight discoloration in the area. It'll be a little more swollen than your grade 1. And that could take up to 2 months, but usually can be 2 to 4 weeks. In some cases, take a bit longer. But the thing with ankle sprains and a lot of injuries is you really want to take care of how you manage it, especially that first time you injure it, but even going after, because you often hear people have ankle sprains and they have bad ankles, weak ankles, and it's, oh, I just sprained my ankle once and then it just kept spraining. And you can't necessarily fully restore like the ligament in this, especially if it's more severe ankle sprains has been happening more often. But what you can change, and this applies like for anything with the most areas of the body actually, like even if you can't change the structural things like the bone or the ligament, most of the time your muscles are something that you can always affect and change. So it's basically like if your body has multiple ways of supporting the same area. It's like a building has support pillars, but also has, some of the support pillars are taken out, the whole building doesn't fall. So you might not be able to get some of those fallen support pillars, really depending what I don't know, I'm holding this like this. Depending on which ones are kind of taken out, but you can always, strengthen your muscles and improve your balance. And that's really where, especially if you're having chronic ankle injuries, that's really what you want to try to change. Like if you're going somewhere and they're, just helping you manage your symptoms, but they're not, having a conversation with you and letting you know, like, hey, like this keeps happening and you still want to use your ankle. Let's say even you're not even playing sports anymore, right? Like you just want to be able to use your ankle just to walk around and play with your kids, and like it's always flaring up, bothering you. You're tweaking it, or you don't feel like you can properly and safely play with your children, right? So so it really gets down to when you're working with us, like figuring out where your goals are, where you're at, and then bridging that gap between your goals are kind of what you want to get to, and the back to that low tolerance. This is the low tolerance, and your goals is where you want to be. So helping you try to bridge that gap. And part of that is helping you reduce some of the irritation that's there, but especially if it's something keeps happening, we want to get to the root of it, which is helping strengthen whatever's weak, and stretch whatever's tight and all those things, and give you some tools so that, let's say you come in, you sprain your ankle, you have this Achilles tendinopathy, you finally get it under control, you get the exercises going. Then in the future, you have the tools if something minor happens, okay, like let's say you saw myself, Najih told me with this, and this happens, to ice the area, to do these stretches, we tried this, strengthen, and we talked about why it can happen, to manage load, etc. And then then you can always, if those management strategies don't work, then you come in and then we work on it together. And if it's the same problem, then that's, we go through similar process. Or if it's something completely different, then we go through taking it through a completely different route. Like, and even if it's just you come in and it's just a flare up of your symptoms, and we're just working on managing, right? It's really helpful to at least have someone in your corner where you've seen them, especially if you've seen them before for this injury, or if you've been trying to manage it and it's been sticky. Really important to work with someone and get get it under control, and have someone who's in your corner and has been there with you before in this situation, can help get you out. Because even like, I'll give you guys the I'm seeing a bunch of questions come up. Yeah, I'll answer that in a sec. Even if for myself, I'll use myself as an example. Like, I do have the knowledge, for example, to help manage some of my injuries and stuff. But oftentimes, if you're kind of looking at things and you have your emotions into it, and you're like, I want to be able to do this, to be able to do that. Sometimes having a third party is really helpful, because they're looking at things without your emotional attachment to, like, I think I can do this, but I don't know. And then you can kind of help yourself get out of pattern. So even if, you're a clinician watching or something, and you have this thing that's constantly been bothering you, if you're someone who has been dealing with injuries a lot, and you find like, yeah, I know how to sort of manage things, but they still sort of keep happening, having someone just come in and help fill that gap can be really helpful in, helping you see blind spots that you had, and then you guys can work together, and you can tell them what and really give them a good idea of what's worked for you, and they can add in, that synergy. That working together can be really helpful. No problem, Spencer. I had a high grade deltoid ligament sprain back at the end of October last year. Even after a few months, I still have a little bit of fluid filled sac. How do I reduce the bursitis? So in terms of the bursitis, I guess it'd be pretty variable. I'm gonna venture to guess, or I'm gonna make a couple assumptions just to give you an idea of how you might go about managing this sort of thing. So let's say you had the deltoid ligament sprain. Now, um, the ankle has lost some of its stability, right? And also, if you, I'm gonna assume also that there was no surgery or anything that needed to happen. You needed to potentially change the way that you walk to offload and reduce some of the pain you had. So that could have been what kind of set off the triggering of the bursitis, where you're walking in a different way, and then something keeps irritating that fluid sac. So I would say try to see if there's something in the way that you're moving that's could be potentially causing you to irritate this sac. And then if changing your walking mechanics doesn't necessarily help, then you kind of have to come in and on an individual basis see, like, is there some hands-on things that um, uh, physio or chiro could help you with reducing? Is it just that there's range of motion that's lacking elsewhere, that is, even maybe without this deltoid ligament sprain, just brought it and made it like more prominent, but that there was already something underlying there. So really, it kind of depends, and it's pretty case by case. But I would recommend having, if you haven't already, go see someone to take a look at that, or if you're still in contact with your GP, or whoever you kind of chatted with to get the diagnosis, to follow up with them and see what their thoughts are as well, because they've been working more with the case. What are some specific exercises to help with my balance? And we have, I sprained my ankle after. Okay, so specific exercise for balance. So you first start with just basic single leg balance stuff, as well as you'd also want to do things like that are just on one leg, but working on your balance in a squat or in a lunge position. And then from there, based on what you're trying to get back to, but also in general, you start adding things that make it more challenging. So you could add a weight in, you could add something pulling you to the side to make you have to control that weight shift. You could have someone working with you, making you wobble. You can be on unstable surfaces. So really, you could do many things, but you start with sort of more basic things, and then begin to make them more challenging, and increase how much demand you're placing on your ankle, but your whole leg and the mind as well. And I've sprained my ankle after doing. I hope that answered those two questions. Please let me know if you need any follow up on those. I sprained my ankle after doing a high jump. It's been about 10 years. When I walk for about 20 minutes, my Achilles starts to hurt. Any thoughts? 10 years. So based on that, I'm not sure how bad the ankle sprain was, and since it was 10 years ago, my first guess wouldn't be that it's the most relevant thing, unless you started having pain from that point, and that pain that you get is where you sprain the ankle. But it sounds like it's more the Achilles that's hurting. So I would venture to guess that it's more along the continuum of Achilles tendinopathy. Um, but let's say even going broader from that, because we can't, if I'm not even making that assumption, right? I would go about kind of looking at that as okay, look at, is there any limitation of your movement of the ankle, and then go into strength. Like we know it doesn't handle too much walking, right? After 20 minutes starts to hurt. So we know that that's the kind of 20 minutes is like max capacity, right? So there's probably some significant weakness somewhere in the ankle. Most likely, I would venture to guess it would be the muscles at the back of the calf just because the pain's at the Achilles, but that could just be compensating for something elsewhere, right? So really, it would first start with identifying what are some deficits there at the ankle, right? And things that you could identify, things that you can work on that are a lot, and then just going through them systematically, trying to figure out, which ones are most likely to be affecting the Achilles and going from there. And in the meantime, just trying to manage your symptoms and still going for walks. But you could, for example, go 2 10-minute walks rather than 1 20-minute walk. Got another, hopefully that helps. Just getting close to the end here, but if you guys have any other questions, please feel free to ask. I see one question here that I'll get to in a sec. If the people who are in the YouTube video, oh sorry, the YouTube stream could leave their initials in the chat, just so we know who joined and we can give you guys some additional info or a summary of what we talked about, just so you have it as a resource for you. That'd be great. So please do so whenever you can. Ankle sore, tight, hurts. If I go for a walk, when should I stop walking? Also heat or ice. VTL, I'm not sure if the ankle's sore tight before or after you go for your walks. I'm gonna assume that it's it's tight beforehand and then after it becomes sore as well. So similar to the previous question I was answering where, I was saying figure out they know their walking tolerance is 20 minutes, that's when things start to hurt. I would figure out what your walking tolerance is and you want to start going for walks that aren't aggravating it. So let's say your walking tolerance was, excuse me, 15 minutes, right? Going for shorter walks where you're not in the cycle of every time you walk, you're aggravating, right? So finding a distance you can walk that's even less than that 15 minutes where things start to hurt, 10 minutes, and then getting really solid at that. And that'll help you kind of continue to build up strength. And you can go for 2 10-minute walks, and that way you'd walk more than the 15 minutes, for example. And then just figuring out there could be a lot of reasons why the ankle's sore, and I'm not sure where the ankle's sore, but in most cases, you're good with heat or ice. If it's feeling sore after an activity, I would lean towards using ice just because there may be some inflammation that the ice can help reduce. But if you're or before your walk, you could use heat to warm up the area, but either or should help with reducing the irritation that you have. Again, it's hard to answer without knowing the exact injury that you have or where the soreness is and that sort of thing. But if it's something, again, for everyone whose questions that I asked, if these things are something that tends to be bothersome or you want to get looked at or get looked at just to make sure that you're not predisposed to some injury in the future, like you can always seek out your local physiotherapist, chiropractor. Shout out to me, shout out to everyone at Rehab Hero. Just you want to try to, in general, even if you guys are not feeling anything, you want to, in general, even if you guys are not feeling anything, like, or if something's more on the mild, then you want to come in at that point rather than waiting until things are so bad that like you're limping and you can't walk, like, which is common tendency. Yeah. In terms of, let's say you come in and then you're wondering what kind of treatment that we provide, right? Sort of things that we would do are in the first stages, right? Let's say I'll use one of the examples in the chat here. Let's say the two gentlemen who have, or the two, shouldn't assume gender, sorry. The two people who in the chat who have ankle soreness after they're walking, right? So I was chatting about figuring out what's a good walking distance. And then let's say some both have soreness in the calf after walking. So you'd come in, we do some massage at the calf, and then let's say it's tendinopathy, then we have modalities available to us. We can use shockwave, we can use, let's say, a lot of the practitioners here can also use acupuncture. So we use that to help calm down the system. And let's say there's certain muscles that aren't firing as well. Acupuncture can be really helpful with just kind of jump starting that process. And then from there, managing symptoms, and then we start to tie and we'll always give you some homework as long as there's no reason not to. Homework being just some exercises, some stretches, so that the things that we're doing is just to open a window for you to come in and take advantage of that. So we work on the area, we do some joint mobilizations or work on the range of motion, stretching, whatever we do, all those types of things that we do. You know, we help create we it'll feel hopefully feel good, but also give you that space in the joint or that looseness in the muscle where when you're doing your exercise through the week or strengthening, you're stretching, all those things that you're making those changes last, right? So, and it's a really like integrative thing where we're working with you to try to come up with something that is feasible for you, that's achievable for you, and that's getting you towards your goals, right? So it's really a team effort here, and everyone here at Rehab Hero takes that approach where we really make sure that treatment's not just based on like, oh, like, let's say two people come with an Achilles tendinopathy. The two treatments could be completely different because they could have different reasons why it's happening, different timelines. Like one person could be a more simple one where it's been 2 weeks. One person could be where it's been 6 months. Treatment's going to be completely different, and those conversations are going to look completely different, right? So, ultimately, like with all those things, like um, we really take pride in making sure that we listen to what's going on with you and taking your health very seriously and trying to get a good understanding of what's going on, right? And not just treating just the sore area or whatever it may be, like figuring out okay what's at the root so that we can prevent this sort of thing from happening. Yeah, so we're just past 8. Does anyone have any last questions? And if you haven't had a chance to, please leave your initials in the chat. All right, while we're waiting for that, hopefully I wasn't stuttering too much. Thought I wasn't nervous, but I was kind of nervous. First time doing this thing. First time for Rehab Hero, so we appreciate you guys joining us. And I appreciate you guys joining me. Hopefully I kept your guys' attention, answer your guys' questions well. And if you guys have any feedback for us about this whole thing or how we can make it more interactive or make it easier for you guys to ask questions, or if you want us to spend more time answering your questions, let us know. So lastly, I guess I should go into the next, what we're going to talk about in the next few sessions. So in the original email, we were discussing a 4-part seminar where, depending on response to this one and your feedback, we're going to either go with a 3 or 4 sessions, so at least 2 more sessions. So what we're going to be covering in the next sessions is going more into the rehab side of things. So going into more specific exercise examples for strengthening and cases where what the approach I would take to in X condition, Y condition, whatever condition, and then going into how care would look like in a more acute stage or when things are more irritated versus then looking at what it looks like when you can get into the more management phase and just going through the whole continuum of that, and then going into a bit more of the balance stuff and that sort of thing, and then whether in the second or the third, depending kind of how questions go and the timing goes, then going into more higher level stuff and getting more into sport specific stuff, plyometrics, that sort of thing. And also if there's more conditions people wanted me to talk about next time, would you be able to show the exercise? Yeah, that's the plan. That is the plan. So that way I don't have to be sitting here. I'm not a desk sort of guy, so that'll be more fun for me. You guys might have to bear with me being tired and breathing, though. I haven't been doing these exercises as much as I might need to. Just gonna make sure. And if you guys have things that you want me to discuss as well, like you can let us know, right? So this is really something that's for you guys, right? Like we're hosting this, and we're hoping that this will be something that we continue to do, where we're providing information for people in the community, right? Like, and just informing you guys of how to take care of your health, right? Because ultimately that's what we want to help with. We're here to help you guys and be an information source. So, and this is just a medium for us to, this is just a medium for us to go about doing that, right? Myself, I'm doing the first couple presentations, but other practitioners will be doing some through the year, and we all want it to be something where we're doing this to help you guys, right? So if you're interested in the future ones, or which we'll be giving you more information about as we kind of go into developing that. Like for example, the next series will be on weightlifting and going into things you want to think about for squatting and deadlifting and all that sort of thing, which will be hosted by another one of our physios. But if that's something you're interested in, like let us know, right? Like, or if there's things that you would want to know about, let us know too. Like we really want it to be for you guys. So it looks like hopefully I answered everyone's questions there. We're just about ready to wrap up on our end. I'll leave another 30 seconds just if anyone has any last minute questions. Side note, I did not think that I would be using this as much as I did, but I'm glad we unscrewed it because we were debating not unscrewing it. Hopefully it didn't look awkward, except at the end there. Okay, I think we're going to wrap things up, guys. Thanks for joining. Have a good night. Bye.